Okay, so good morning, everyone. So today we will start a new topic, which is the neurologic emergencies or care of patients with neurologic emergencies. And the focus will be on the CVA, stroke, and TIA, and the uh, risk factors, the management and nursing care of patients with stroke. Does anyone have any experience with patients with stroke, like in a hospital or long term, or can anyone just describe the some of the manifestations they can recall about the patient if they had took care or assigned to a patient with stroke, CVA?
I work in a stroke unit,
Hmm,
so
great, go ahead.
oh gosh. So I mean, it depends what side they have the stroke on. So, their speech is usually they could be like aphasic, by either just like saying really random words or like not even words.
Mm-hmm.
Um,
Meaningless words, right?
yeah,
Yeah,
but then
yeah.
sometimes they'll say a sentence like the flowers on the ground.
Mm-hmm.
Like they're really just trying to ask to go to the bathroom or something.
Right.
They have like weakness on one side of their body.
Mm-hmm.
Um,
Hemiplegia. Mm-hmm.
what else do they have? Those are those
So
are like
what about the swallowing? Have you seen them like having swallowing
right.
problem, right?
Yeah, they have like swallowing problems, so we'll put them on like diets like either their MPO or we could put them on like a puree diet or
Yeah, thickening
yeah,
the
like thickened
yeah, thicker
liquids
liquids. Yeah,
so that they don't aspirate on the thin
yeah,
liquids.
nectar thick or honey thick or right. Yeah, visual problems like
Um, I-
diplopia or loss of vision or
I'm not sure about that one.
yeah. So see, it's a wide range of neurological deficits and disabilities. There is no one, you can attest to that. There is no one clinical picture of all patients with stroke. They will look the same, right? Or they will exhibit the symptoms, same symptoms or manifestations. It's a wide range of change, of symptoms, and we'll get, into why would you anticipate that, patients with stroke will have different intensities, different levels of, of these, what is called neurological and sensory deficits. Some of them are permanent, others would be just transient, and we'll go over that too as well. Thank you. Any other experiences with stroke patients, like one of the assigned patients, that have a history or um, acute episode of stroke or CVA? Anyone? No.
Yeah, like my patient last clinical, he had like a minor CVA.
Mm-hmm.
He wasn't too bad. He had left side weakness, and I think that was about it. His was very minor. I didn't see like too many other symptoms.
Right. Yeah. So the weakness, we'll go over. Also will go over this, which is that the weakness can range from just numbness and paresthesia, and go to the paresis, which is the weakness, paresis, or hemiplegia. Hemiplegia means paralysis. So it goes, we have a wide range of changes in terms of neurological, which is motor and sensory alterations. It goes from the least, which is numbness and tingling sensation, which is paresthesia, to the weakness, which is paresis, and then to the plegia, which is the hemiplegia, which is the paralysis. This is complete loss of motor and sensory function. So this is just in mnemonics, just to how to recall this risk factors for the CVA or stroke using the live the way the coach should, which is there are nice mnemonics they can just recall, so you can Remember all the in risk factors, modifiable versus non-modifiable risk factors. The other causes of or risk factors, for CVA or stroke, we can add to that also the sickle cell anemia, which pertains to the PEDS course, right? So the patients with a hypercoagulability problem, that they have a high coagulation rate of producing or forming and developing a blood clots and thromboses. Um, the path in etiology and pathophysiology, these slides provide you with a lot of information about so you can review the patho. The one thing about Courtney and uh, and more was saying about the stroke is that the severity of the loss of function, it varies according to the location and extent of the brain involved. So it depends on the location of the brain, the site which has been affected by the stroke, the resultant sensory and motor function deficits, if that's permanent or transient. These are the two main factors: the location and the extent of um, the insult of the brain tissue, the insult to the brain tissue by that infarction. Because we'll go over the different types of strokes. Could be thrombotic blood clot, embolic thrombosis had formed somewhere else, like in the heart or the DVT or pulmonary embolism, and then travel to the brain. That's embolic stroke. And then the third one, which could be that patient, which is most high likely hypertensive patients, hypertensive crises would result in the rupture of the blood vessels in the brain. Then that's become a hemorrhagic stroke. So it can be ischemic or hemorrhagic, and we'll go over these three different types, which is ischemic, two different subtypes, thrombotic, embolic, both ischemic, belong to the ischemic, and then we have hemorrhagic. So these are the three main types of strokes. The perfusion to the blood, to the brain, is perfused or completely done by two main arteries, carotid. That's why under the etiology, you will find patients with carotid stenosis and atherosclerosis, especially with the carotid, they will end up with the stroke. So that is something that has to be addressed and has to be taken care of, so we can prevent the strokes if so early detection and treatment of the carotid stenosis, that it will prevent the episodes and the stroke episode. Another slide about the patho talks about the perfusion to the brain, which is the auto regulation in the brain cells. They are able to, or they can regulate their, the perfusion, and that is consistent with um, the rule, which is that the changes in the diameter of the blood vessel, it will change, will alter in response to the changes in the pressure. So the pressure and the diameter of the blood vessel, these two things will work, in concert together to maintain the perfusion to the brain. And it's very critical when it comes to the brain cells, because the brain cells, they rely heavily and 100% reliance on the perfusion. There is no any reserve there. So the cellular death will occur within 5 minutes with the complete cut blood supply. If there is a complete interruption of the blood supply within 5 minutes, the brain cells will die within 5 minutes of the complete interruption of blood supply. The factors that may affect the flow to the brain cells mostly will. So, what do you think about the factors? Factors that will increase or decrease, in this case, should decrease the perfusion to the brain cells. What could be these factors? What makes brain cells to be perfused with less blood?
I'm guessing a disease that like maybe or just like you're like when you have, I guess, obesity eventually will lead to the development of like, or like hyperlipidemia will lead to the development of like
atherosclerosis would be one of them, but what would be the factors that may affect the flow to the brain cells, the flow, blood flow, perfusion, the pump, which pump perfuses the blood and send the blood to the brain? The myocardium.
Like lowered cardiac output.
Yes, exactly. So the decreased cardiac output significantly is going to decrease the perfusion to the brain. Blood viscosity, if there is any high viscosity of blood, increases, then definitely is going to reduce the perfusion. In addition to that, remember that we said that the mean arterial pressure, the MAP, the textbook talks about the systolic, but we will focus on the MAP more than the systolic. The mean arterial pressure, which is systolic plus 2 diastolic over 3, that is the mean arterial pressure, the MAP. So the MAP plus, even you can see systolic, the textbook again focuses on the systolic, but we will focus more, the MAP is more determinant of the perfusion to the brain cells more than the systolic, mean arterial pressure. So decreased mean arterial pressure, decreased cardiac output, increased blood viscosity. These are 3 most significant factors that will change and alter the perfusion to the brain cells. Atherosclerosis is the major cause of the stroke, and that because it will lead to the thrombus formation and blood clot, and then contribute to also to the emboli. The TIA, and we have something called REND or RIND, which is the we'll go over that. The TIA. What is the TIA? How it's different from the CVA? So the TIA, which is the temporary loss, and it's a focal loss. So it's transient ischemic attack. So it's ischemic attack to the brain cells, but it's transient. It will resolve within 24 hours. Most cases and scenarios of TIAs, they resolve within like an hour, but it can take up to 24 hours. So it's a temporary focal loss of neurologic function caused by ischemic changes.
Wait, you said it takes up to 24 hours?
Up to, yeah, the max is 24 hours. But most scenarios and most cases within an hour. The textbook talks about the TIAs, most of them resolve within 3 hours, Other textbooks, they say like within an hour, the majority of the cases, but it doesn't take longer than 24 hours for complete resolution of all the symptoms. If there was like visual changes, numbness or paresthesia or any weakness to one side of the body, all these symptoms will be resolved within 24 hours. So this is due to presence of microemboli. That's why it is transient ischemic attack. It's a microemboli, it's very small, tiny blood clot. The gold standard for the diagnosis of a TIA or even a stroke is a brain CT without contrast. That's the initial diagnostic study, and I'll talk more about it in thereafter, which is the brain CT without contrast, non-contrast brain CT. So the underlying causes or the underlying cardiac condition should be addressed and should be taken care of, such as, what do you think would be like the underlying cardiac condition that is responsible for the clot formation? Which cardiac diagnosis could result in blood clot and then blood clot to travel to the brain and cause a stroke?
AFib,
atrial fibrillation. So cardiac monitoring and tests can reveal underlying cardiac conditions such as atrial fibrillation. The AVM2, atriovenous malformation, that also is another risk factor that can result in a stroke, and most likely it's going to result in hemorrhagic stroke, because that's The structure of the blood vessels is very thin wall of the blood vessels, spaghetti-like mass of malformed, thin-walled, dilated vessels. So that would result, and especially when the patient has a high blood pressure, then that will result in rupture of these blood vessels and then the hemorrhagic stroke. This slide provides the table that can present table compares between the thrombotic, embolic, both of them under ischemic, and the hemorrhagic stroke in terms of the evolution, the onset, the level of consciousness, and the other aspects or features of each type of the three different types of strokes. So the C, which shows the hemorrhagic, when the blood vessel ruptures in the brain that results in hemorrhagic stroke, and then the ischemic, either it's embolic, like patient who had developed DVT and then blood clot travels to the brain, and that's embolic stroke. Patients with atrial fibrillation, blood clot formed in the heart, then travels to the brain and results in embolic stroke. Patients with pulmonary embolism, blood clot dislodged from the lungs and travel to the brain, or any embolism or embolic any fragment can foreign body can travel to the brain and result in embolic stroke. And then we have the thrombotic stroke, which is the blood clot that has formed in the brain vessels itself. So it's right there. So it has developed right in the brain blood vessels. So that's thrombotic. Both embolic and thrombotic, they are ischemic. So anytime you hear ischemic stroke, it could be embolic or thrombotic. The clinical scenario, let's, as we read the scenario, we take notes or underline or highlight certain words and sentences. Any volunteer to read out loud, please?
I can read it.
Thank you, Trenton.
A 72-year-old man is admitted to the hospital because of an acute onset of right facial droop, right arm weakness, and some difficulty speaking. These symptoms started 6 hours ago while he was sitting at the breakfast table. He had no headache, no diminishment of consciousness, and no abnormal involuntary movements. 2 weeks ago, he had a transient painless loss of vision in his left eye, which resolved spontaneously within a few hours. His medical history is significant for long-standing hypertension and myocardial infarction 4 years previously, which was treated with percutaneous angioplasty. His medications include daily aspirin, metoprolol, and simvastatin. He does not smoke. When you see him in the emergency room, his symptoms have nearly resolved. He is afebrile, heart rate is 62, blood pressure is 135/87. The corner of his mouth droops, but he is able to fully elevate his eyebrows. His strength is 4 out of 5 in his right arm and hand. And the rest of his neurologic exam is normal. He has no carotid bruits. His heart rhythm is regular with no murmur, but with an S4 gallop. The remainder of his physical examination is normal. Laboratory studies include renal function, liver function, lipid profile, and complete blood count, all normal. Within a few hours, all the patient's symptoms have resolved. What is the most likely diagnosis and what is the next step?
So this is the question for the entire group. What do you think? What is the most likely diagnosis?
The transient ischemic attack.
So it's a TIA because
The symptoms resolve within a few hours.
the symptoms has resolved within 24 hours. And if the symptoms stayed longer, with resultant, let's say, hypothetical question here. If these symptoms stayed longer than 24 hours and these are permanent, like patient continue to have that week, so what would you highlight, first of all, about the TIA? So we can underline the right facial droop, right arm weakness, difficult speaking, all this consistent with the motor deficits. The patient, what about the risk factors for this TIA?
I think he has hypertension, so that definitely.
Hypertension, and also the patient has a previous TIA, which is the transient painless loss of vision in his left eye. That is also another TIA the patient has experienced 2 weeks ago, because that resolved also spontaneously, which is another TIA. So patients, so what's the danger of the TIA? What's the significance about it? So we know that the patient is going, it's transient, so the symptoms are going to resolve within an hour or 3 hours, a max of 24 hours. Patient's not going to develop any permanent deficits, sensor or motor or any type of deficit. It's not going to be permanent, so that's transient. So everything going to be resolved. So what's the danger of the TIA then?
I'm guessing where it happens, like if let's say like the patient is driving, and then it happens, and then.
Okay, so if that's motor deficit instant, which is even transient, that could affect patients, if the patient is driving, patient doing sensitive kind of things, or for safety also, problem. But what about the frequency of the TIAs? Patient who had developed more than one TIA.
Well, then it's a warning, because it can be progressive for CVA.
It should not be ignored. It should be addressed and evaluated, and because that is a warning sign for future CVAs or strokes. It has to be taken care of, at least to be addressed, to be evaluated to see what is the underlying causes, so we can prevent the stroke in the future. Because that's a warning, one of the significant warning signs or warnings for future strokes. So it has to be addressed. So what is the next step then? So if a patient has a TIA, saying that everything has been resolved, all the symptoms, should we not just to progress to go to the next step to evaluate and do some diagnostic testing?
Oh yeah, I was about to say, we can do further testing.
Like?
It says he has a percutaneous.
Yeah, gold standard always CVA, stroke, TIA. Gold standard is that even a TIA, the next step is to perform a non-contrast CT of the head. Non-contrast or CT of the head without contrast, that always should be the gold standard for all different types of CTs. So the CT, the brain CT with no contrast, it's not going to tell you any specifics about the blood clot. If there is blood clot, how big. If small ones, not going to to be even shown and revealed in the CT without contrast. But at least it will differentiate and tell us if there is any hemorrhagic versus thrombotic or embolic. The CT, the significance about the brain CT with no contrast immediately after the incident is that to rule out the hemorrhagic stroke, because it's if that's stroke, then also that will give us a better guidance, right, about the treatment. You don't want to treat patients who hemorrhagic stroke with heparin or with a TPA or right, so with anticoagulant therapy. So the CT, the significance about the CT without contrast is to rule out the hemorrhagic stroke, because you can easily find the hemorrhage on the CT with no contrast. Can be easily detected, So if that's thrombotic stroke, CVA and thrombotic stroke, then the patient should be treated with the thrombolytics. And thrombolytics, which is a TPA, tissue plasminogen activator, the same drug that we have used in patients with acute MI, because that's a it will dissolve the blood clot and disintegrate blood clot, and that's thrombolytic medication. And that is, we said in the cardiac event, like acute MI, we can use it up to how long? That was a time frame for acute MI for the TPA.
You said up to 3 hours?
No, for acute MI. It should be longer with the acute MI, myocardial infarction. It's longer than the 3 hours.
Oh, six.
Up to 6 hours. Yeah, up to 6 hours. But for the optimal effect, up to 6 hours with acute MI. But with the brain blood clot, stroke, you can use it up to between 3. The max is 4.5 hours. The best, the optimal effect or outcomes of using the TPA with thrombotic stroke or embolic or ischemic stroke in general is the 3 hours, the optimal, but you can still use it up to 4.5 hours with stroke. So that's for the TPA. That's the difference between the using or prescribing the TPA or thrombolytic medication to a patient with acute MI versus patient with a ischemic stroke.
Wait, I'm sorry. What's TPA again?
It's tissue plasminogen activator, like Ritaplace. There are different brand names for the TPA, which is tissue plasminogen activator, and we use it for both infarction, myocardial infarction, acute MI, and the ischemic stroke. And the classification as a thrombolytic medication, so it will dissolve blood clot and disintegrate the blood clot. It's different than the heparin and Coumadin because the anticoagulant is to prevent the future clots. This one is going to take care of the already formed blood clot. So the highest risk patients for stroke are those with previous ischemic events like TIA. So TIA is the major warning sign, significant warning sign for a stroke. So next question. Volunteers?
I can read it.
Go ahead.
A previously healthy 75-year-old man experienced a TIA 2 weeks ago. On physical examination, he is found to have a right carotid bruit. Duplex ultrasound demonstrates a 75% stenosis on the right carotid artery. Which of the following is the best therapy? So would it be A? Right answer?
So this patient has symptomatic carotid disease.
Would it be D?
Which include symptoms of TIAs, episodes of blindness, and the ischemic stroke is non-disabling. When the assessment finding says the right carotid bruit, means there is a turbulence of blood at the carotid artery, right? Which means there is a atherosclerosis. There's a plaque that is obstructing the carotid artery, and we said that the patients with carotid artery problems, like atherosclerosis or carotid stenosis, they are at risk for TIAs and strokes.
Is it C, the carotid
Right.
atherectomy to clean out the carotid?
Exactly. So it's a significant treatment or modality is to take care of the underlying cause, which is the endarterectomy, carotid endarterectomy, which is the surgical procedure, invasive, that they open the carotid artery and they remove and they shave off or remove the size, that plaque formation that is obstructing the carotid artery, because that is the source of the decreased perfusion, which has resulted in the TIA. So a patient who presents with symptoms or symptomatic carotid disease like carotid stenosis, between like 70 and 99%, it's a lot of stenosis, which means the lumen is almost like completely blocked, which will result in significant decrease of perfusion to the brain cells. So those patients, they should receive or should undergo the carotid endarterectomy. It's a surgical procedure to remove the plaque, remove the atheroma, and then to increase the lumen of the carotid artery. So this next slide is differentiating between the TIA and the RIND, which is reversible ischemic neurologic deficit. We don't usually use it in clinical, in terms of the clinical implications, or correlations. We don't use it much as you use the TIA. We always say TIA versus stroke, but we don't use that RIND. The RIND, it's the higher on the scale of in terms of, it's like a TIA. It's a TIA, but it has to do with the time of resolution of the symptoms of the resultant deficits, if there is any deficit, which is temporary transient, it's not permanent. And the RIND, it takes longer than the TIA for the complete resolution. The TIA, we said, all the manifestations or symptoms or sensory or motor deficits, it takes up to 24 hours. It will be completely resolved. Patient will, after 24 hours, have any resultant permanent deficit. So that's a TIA. The RIND, which is the symptoms that may last longer than 24 hours and that should be less than a week. So a patient who had experienced a difficult speaking or swallowing problems or visual diplopia or right side weakness or right side paresthesia, and that will last longer than 24 hours, that could be what is called RIND. This is reversible ischemic neurologic deficit. As I said, most patients, they develop TIAs more than the RIND, but that's could happen in terms of the patients who develop the TIA, which is prolonged longer than 24 hours. That is the RIND. That's the difference between them. It's just the time that takes for the symptoms to be returned or back to normal or to be resolved. So the symptoms I see here, the symptoms, it's like it takes longer than the TIA. It's the same thing. It's just TIA and RIND, the symptoms or symptomatology will be the same. And again, doesn't mean that all patients will experience all these symptoms, but it varies. It depends on the side of the brain or the location of the brain or cells being affected. Then that will result in the associated signs and symptoms uncorrelated with the location and side of the insult to the brain. So that's the difference between them. And then we have ischemic stroke, thrombotic, and then lacunar stroke, which affects the small blood vessels in the brain. The ischemic stroke, we said that's thrombotic or embolic, and then we have another classification called hemorrhagic stroke. So the ischemic stroke, 85% of all cases or stroke patients will experience what is called the ischemic stroke, either thrombotic or embolic, unless it's lacunar, which is affecting the very small tiny blood vessels in the brain. The thrombotic is the most common type of stroke. As we said, the results of thrombosis or narrowing of the blood vessels. Embolic That's the second most common cause of stroke, and we have mentioned and included some of the examples of the embolic strokes, which is the blood clot or thrombosis that will travel from somewhere else and aside or outside of the brain, like the lower extremities, lungs, heart, like AFib, and then when it travels to the brain cells or blood vessels, and it will result in embolic stroke. The patients with the embolic stroke, commonly they have a rapid occurrence. So the signs and symptoms, they are very rapid. And the clinical manifestations are more severe than the other types. The onset is sudden, and most of, the headache, it will be also in hemorrhagic as well, but on the onset of the embolic stroke is usually sudden in terms of the onset of the symptoms. The patient, usually they remain conscious, although may have a headache. So they will complain of headache, but the headache and the hemorrhagic stroke will be severe headache, and that's the worst scenario of severe headache would be in hemorrhagic stroke. But here in embolic also they will have headache, but the patients usually remain conscious, although they may have a headache. With the hemorrhagic stroke, that's when the patient will complain of the headache, and it includes also the neurologic deficits, the neuro deficits, sensory and motor deficits, the headache, nausea and vomiting, and decreased level of consciousness, hypertension, and elevated blood pressure. The most important cause of the intracerebral hemorrhage, which is hemorrhagic stroke, is what would be the most important cause, like etiology, that would result in the rupture of blood vessel in the brain and result in intracerebral hemorrhage, which is a hemorrhagic stroke. Like number one, in terms of the etiology. The first cause would be, any answer? What do you think? What will make the blood vessel to rupture?
High blood pressure.
Yes. Hypertension is the most significant cause or etiology for intracerebral hemorrhage and resultant is hemorrhagic stroke. The hemorrhage could take place inside the brain cells or brain itself, like intracerebral hemorrhage, or subarachnoid, subarachnoid hemorrhage between the arachnoid and the pia mater. One of the characteristics of the symptoms of the ruptured aneurysm, if that's an aneurysm resulted in a rupture, that will be described by the patient as the worst headache of one's life. So that's kind of description of, once you hear, the senses of patients or these kind of, of the nature of the pain or characteristic of the pain as the worst kind of, headache of their, of one's life, that is the most severe type of headache they have experienced. That is one of the indications that could be the rupture of aneurysm in the brain. So we treat it by the surgical modalities or procedures to treat this type of hemorrhage, especially when there is a ruptured aneurysm. Coiling, one of the techniques or one of the surgeries done. The manifestations of the MCA, which is the middle cerebral artery, which is the most common artery that's going to result in a rupture and then the hemorrhagic stroke, MCA rupture. It will result in you can use this mnemonic of changes, C, which refers to the contralateral paresis, which is the sensory loss. Paresis, which means these tingling sensation and numbness. Contralateral means the other side. So the brain cell, brain like middle cerebral artery, and the right side affected, then the left side resultant contralateral paresis and sensory loss. Mostly would be in the face and the arm. So contralateral paresis and sensory loss in the face and the arm. H, which is the hemiparesis, which is the weakness of the other side, right? So right side brain, middle cerebral artery bleeding, then the left hemiparesis. So hemiparesis, the H, and then the A, which is aphasia, and the N, which is neglect, and we'll talk about the neglect syndrome, and then the G, which is the gaze preference towards the side of the lesion. So patients will be kind of looking at the side of the lesion. That's the G, which is gaze preference toward the side of the lesion. There's a lot of information about. I'm not expecting you would recall all the details about what's like specific symptoms associated with a vessel rupture or a vessel disruption, because middle cerebral artery will result in specific symptoms. Anterior cerebral artery, and different symptoms. And so each, like the presence of the hemorrhage or blood clot in any of these specific arteries in the brain would result in specific symptoms. So it's just, we will go over in general, what is the clinical manifestation, and patient can, there is no one clinical picture of, all patients with stroke. They'll be, exhibit the same clinical picture. So we have a wide scale of, from just numbness and sensation, weakness on one side, to paralysis of one side, like paresis, hemiplegia. So yes.
Sorry, on the last slide, what was the H again?
I'm sorry, the hemiparesis.
And
so I'm sorry?
What is that?
Paresis means weakness. Paresis means weakness. So hemiparesis means the weakness of one side of the body. So if the brain insult to the brain is on the right side, like the hemorrhage or the clot, and affected the right side of the brain, then the left side of the body would be affected. The upper and lower extremity will have either tingling sensation, numbness, which is paresis, and then or the weakness or the paralysis. So the changes, which is the manifestations, most of the patients with a stroke, they will eventually develop the permanent deficits, motor deficits, sensory deficits. So these slides provide you with all the information about the manifestations. But again, we didn't have like one clinical picture of all patients with CVA will exhibit the same manifestations, because we said in the second slide that the severity and the extent of the injury, it's consistent with the location and the site of the insult. So we have a clinical scenario. Any volunteers?
Yeah, I'll read it.
Thank you.
We have an 82-year-old woman presents to the ED with a 2-day history of difficulty speaking and weakness in her right face and arm. During the interview, she speaks in 2 to 3 word choppy sentences, but can follow commands. She cannot repeat what you say. Where is her lesion?
Yeah, I'm going to this is just an example of, clinical scenario of a patient with CVR with specific like manifestations. And I'm not anticipating that, even the answer, but at least just to show that, each clinical scenario is completely different than the next one. So this patient presents with broca aphasia, which is the aphasia that will result in unable to speak or difficult speaking because of the we have two different places or sites for speech centers, one Broca's area and Wernicke's area, two different areas. This one is the Broca's area that's been affected, so that's Broca's aphasia. So in Broca aphasia, which is BROCA, that's the exact location in the brain that's responsible for one of the two places responsible for for speech. Broca aphasia, that in that specific area or lesion, site, the lesion in the posterior frontal cortex of the dominant side of the brain. So we can tell, from the manifestations and indicate where exactly the site or affected or involved in the brain and resulted in this specific speech problem. So which is the left side. This is the speech difficulties that resulted from the frontal cortex and the left side of the brain. We have different types of speech problems, global, and the two main areas that are responsible are Broca's area and the Wernicke's area. And here, these two tables provide you different types of the speech issues, and each difficulty is presented in different scenario, it provide you with more even details about these specific speech problems. Dysphagia, dysarthria, it's expressive versus receptive, and we have also mixed and global. But most of the scenarios you will have expressive versus receptive, and I'll go over some of the examples in the upcoming slides. More manifestations or clinical manifestations of different types of strokes can affect also the spatial, perceptual, elimination, affect, intellect, or intellectual function. The right versus left hemisphere. So this slide provides the most prominent, or I would say the highest prevalence of the right side versus the left side in terms of that the resultant manifestations. For example, the impulsivity. Anytime you see the patient is a more impulsive behavior, you will automatically think of a right side or right hemisphere CVA. So right side or right hemisphere CVA which is one right here, right? This is a right hemisphere CVA. Because sometimes as we present the scenario of the CVA scenario, we kind of become confused. Are you talking about the right hemisphere CVA or the right side weakness? So we have to be specific. Most of I would say all the time, clinicians, when they talk about the CVA as being presented to any rounds or clinical rounds or more or to as presentation, we always refer to the resultant weakness or resultant deficit. We say a right side weakness, for example, left side weakness, left side hemiparesis, right side hemiparesis, left side hemiparesis, right side hemiplegia, left side hemiplegia, which is, but we implicitly stating that the patient who has resulted in a left side hemiplegia because of the right side insult to the brain. So the stroke itself, so this is the right hemisphere CVA, but which resulted in a left side deficit, sensory, motor, and other deficits. So in general, the right side or the right hemisphere CVA will result in left hemiplegia, left visual field deficit, spatial perceptual deficits, like perception and on space and and not knowing if they are like in bed or they are like on the floor, or that's perceptual spatial deficit. They also, with this type, they will deny or unaware of the deficits. They don't know if they have any visual or swallowing, or they will right away go on to the cup and start drinking, and not knowing or unknowing that they have a swallowing problem, for example. So deny and aware of the deficit. They are also easily distracted. They have a poor judgment, and they are impulsive. So that's for the right side. Now for the left side hemisphere CVA, they will have a right side hemiplegia, right visual field deficits. They will have aphasia, problems with speech. They are aware of their deficits. They know that they have swallowing problem. They don't have the visual problem. They are aware of these deficits. They have impaired intellectual ability. The behavior is very slow, and they are very cautious when they do anything. So that's a slow, cautious behavior. And they are very sensitive to what is called the high level of frustration over losses. They are very careful and very sensitive to any loss. So which lead to, or guide us to, as we plan, or develop the plan of care for this patient about this high level of frustration over losses. So diagnostic tools, we said that the gold standard is the CT. That's the primary diagnostic test used after stroke. So the CT, just want to say something about the CT. Given that also we always say that CT with no contrast, and so what's the significance of the CT without contrast? The non-contrast CT scan of the brain, it must be performed initially, first of all, because it's very sensitive. This non-contrast CT of the brain is very sensitive and detecting acute cerebral hemorrhage, but insensitive to any ischemic stroke. So it's not going to give us much detail about the blood clot, especially when the blood clot is not bigger than 5 millimeters, like smaller than 5 millimeters. It's not going to be revealed on the non-contrast CT, but at least it will rule out or or confirm the presence of the hemorrhagic stroke. So it's insensitive about the blood clot. So in addition to that, so when the area of the stroke is less than 5 millimeters or is located in the brain stem, or if the stroke is less than 12 hours old, it's not going to be helpful. So the result, so anyway, so it's just be clear on this, is that the CT, the non-contrast CT, is the gold standard for all patients suspected to have a stroke. Immediately we have to, the initial diagnostic study should be this non-contrast CT, because at least we can rule out or confirm the presence of hemorrhagic stroke. And we can start the TPA or the thrombolytic therapy at early phase. So other diagnostic tools, MRA, MRI. So the cardiac assessment, we discussed the cardiac assessment or the cardiac testing, like the continuous monitoring or the 12-lead EKG, because you can detect any cardiac underlying causes like AFib. There are measures to assess the blood flow to the blood vessels, like cerebral blood flow measures, like cerebral angiography, for example. Additional studies, you can add to that also the CBC, complete blood count, platelet count, PT, PTT, and electrolytes, renal and hepatic studies. This is from the ATI, from the book. And back to what I was trying to say or discuss or explain, the utilization and the diagnostic study, which is the CT, non-contrast CT. Why the initial CT, it will come as negative for stroke at early phases, like the first, an hour to 3 hours, from the stroke, from the event, then the CT will come as negative. We said that, hemorrhagic, we can easily detect that right away from the non-contrast CT. We say that, either there is hemorrhage or no hemorrhage. What about the ischemic stroke? Ischemic stroke, sometimes it just become as negative. And especially because if the stroke hasn't, so it has to be like from the onset, 12 hours from the onset of ischemic stroke, the CT is not going to give or provide any details. And most of the time is going to be negative, or would give us a negative result. Because the cell death, it doesn't occur immediately following a CVA, an ischemic stroke, thrombotic or embolic stroke. It may take the cell death may take up to 12 hours for cell death to be detected on or by the CT. So this is kind of how would you apply or integrate the CT in terms of non-contrast to identify and to diagnose the hemorrhagic stroke at the beginning, and it's not going to give you much unless the stroke has lasted for 12 hours from the onset to give you more details about the thrombotic stroke or embolic stroke. Because the cell death, it takes up to 12 hours to develop, to be detected by any non-contrast CT. Yes, go ahead.
So for ischemic, you want to wait up to 12 hours, or I'm kind of confused?
No. You have to do this non-contrast CT to find out if there is hemorrhagic, or because if there is hemorrhagic, automatic right away you will find it in the non-contrast CT. But won't give you any details about the stroke if it's ischemic or embolic, thrombotic or embolic, ischemic stroke. It doesn't provide us much details about that, because ischemic means, there is a ischemia, which will result in decreased perfusion, cell death, and it takes up to 12 hours for that to develop, to be detected on the CT. Is that clear, Paige?
Just the 12 hours. I get everything you said, but just the
All right.
12-hour part.
That's the 12 hours, yeah. Okay. The 12 hours is for the blood perfusion to because we have two different types of strokes. We have hemorrhagic and we have ischemic. The ischemic, so hemorrhagic stroke, we can right away from CT, like an hour, 30 minutes from the onset, you can tell, yeah, it is hemorrhagic. And that's the whole thing about the CT. It's not, we don't need, we know that's the deficiency of this specific testing. It doesn't give us details about the ischemic, which is thrombotic or embolic, but we need to know about if this is hemorrhagic or not, which is one of the basic, I would say, significant elements of the treatment, because you don't want to start a patient. We said that it takes up to 4. You see, the TPA, antithrombotic thrombolytic therapy, the optimal result would will show when you start the medication within 3 hours or up to 4.5 hours from the onset. You don't wait 12 hours for the CT to show. So that's the point. You need to, to find out if there is if this is hemorrhagic or non-hemorrhagic.
So what you're saying is that I get a patient in the ER and then I
Mhm.
go to CT and
Mhm.
I rule out hemorrhagic. I could start TPA.
No hemorrhagic, no, you can't.
No,
You
I
can't.
rule it out. I rule it out.
Oh,
It's
yes,
on the
exactly.
CT. I could start TPA because you're saying 12 hours and I know TPA.
Absolutely, yes.
in
That's the
the
whole thing. Yes, exactly. That's the whole thing about the CT, which is to identify, find out if it is hemorrhagic or not. And then when it comes to this, it's not hemorrhagic, then automatically we'll say it is ischemic. So then you will start your TPA right away. You can start, the TPA. Now you don't have to wait for the 12 hours, but the CT is not going to, provide you much of details about the resultant cell death because it takes up to 12 hours for the cell death to occur, right? So that's the whole point about the CT. We have to start the TPA right away. You don't have to wait for 12 hours. It's just from the pathophysiology says that the cell death, it takes up to 12 hours. That's why the CT is not going to provide you much of information until 12 hours has passed so that the cell death will occur. So with like 2 hours after the onset of stroke, then you do, when you have a CT, as you review the CT, the non-contrast CT, it's not going to provide you much of details about the stroke when it's ischemic. Because again, that takes up to 12 hours for these results to be revealed on the CT. Is it still confused, Paige, or?
No, I got it now. Thank you.
Okay, you're welcome. All right, so palliative care, which is very comprehensive, lots of details on palliative care. Remember that we start from day one with the stroke about the rehab therapy. So rehab supposed to start from day one to have not implementing that rehab, but at least we have to have a plan for rehab. After this acute episode or acute treatment has is completed and done. So we have lots of information here about the anticoagulant, antiplatelet. We have to take care of the risk factors like blood pressure, tobacco, AFib, physical activity. It has to be addressed and managed. The anticoagulant, antiplatelet medications like aspirin, anticoagulant like warfarin sodium, which is Coumadin, antihypertensive medications to treat the high blood pressure, and which is most like patients who develop the CVA, high likely if they have the hypertensive crisis, they develop that because of the ruptured blood vessel in the brain, then which resulted in could result in a hemorrhagic stroke. And we talk about the endarterectomy, which is carotid atherosclerosis, in which would result in a plaque or fatty plaque deposition in the carotids, which will result in obstruction or 70, 80, 90, or 100% obstruction, which will decrease the perfusion to the brain. So we have to address that and take care of the deposit atherectomy by what is called carotid endarterectomy, which is the surgical removal of the blood clot of the plaque. Angioplasty, stenting, very similar to the procedures that we had in cardiac. Got catheter to be inserted, and then they will advance the catheter, and they will inflate the balloon to increase the lumen, the size of the lumen, which is the carotid. The TPA, so that's the gold standard, which is we talk about also the if administered within 3 hours, and we said up to a max of 4.5 hours. That would be the optimal 3 hours, but it still will have some positive outcomes, promising results if we implement or start it also within 4.5 hours from the onset of the CVA. And that has to be ischemic type, thrombotic or embolic, not hemorrhagic.
Professor, I have a question.
Yes, go ahead.
Once you start the patient on TPA, do you also start them on blood thinners, or do you give the TPA first and then later start on blood thinners? How would that work?
Just TPA. And this slide provide a lot of information about the treatment nursing intervention during and after the IV administered over the TPA. So after you're done with the TPA, then the patient will done with with the therapy, TPA protocol. Then the patient will be receiving another anticoagulant medication. Can be heparin, can be aspirin, and it depends. The patient is going to stay in the acute care health setting, or patient is going to be discharged to a long-term facility or home, and that will be, for example, like concomitant and or aspirin and clopidogrel, Plavix, for example, aspirin and Plavix, or being on concomitant, but they will be on anticoagulant. And we have many of the recently approved, FDA approved anticoagulant therapy available in the market. So we have contraindications to TPA therapy. The stroke or head trauma within the last 3 months. A, which is the anticoagulation with INR, which is the PT-INR. You can just call it anticoagulation with INR over 1.7, or patients with prolonged TTT. So if values can be corrected using appropriate treatment before 3 up to 4.5 hours, then we have to consider the TPA treatment. But still, this is contraindication for now. Patients with MI in the past 3 months. Patient with the M, which is MI, P, which is patients who had experienced prior intracranial hemorrhage, a previous episode or prior intracranial hemorrhage. L, which is low platelet count, which is significant low PLT or platelet count, which is less than 100,000. E, which stands for the elevated blood pressure, like systolic over 185, diastolic over 110. And again, that's with this one also, if these values can be corrected during the treatment before like 3 up to 4.5 hour period, then we can consider the TPA treatment. So that can be corrected. So once you correct the blood pressure, then you can start the TPA. But as long as the blood pressure is elevated over 185, over 110, then that is a contraindication to the TPA. The surgery, any major surgery in the past 14 days also is a contraindication. T, which is a TIA, within 6 months. Remember that CVA we said which within 3 months, but here a TIA, which is a lower scale, which is minimal, it's within 6 months. That's a contraindication. G, which is a GI or any bleeding from the GI, G, which stands for GI or urinary, like renal bleeding in the past 21 days, or G also stands for glucose level less than 50. E, which is the elevated or decreased, elevated or decreased glucose, like blood sugar, plasma blood glucose level of over 400, or plasma glucose level less than 50, that is belong to the E, and then S, the last one, which is seizures. If a patient develops seizures at the onset of the stroke, so the patient has a stroke and at the same time they develop seizures, that's also will be a contraindication to use the TPA. So this is a very strict list of reasons why you wouldn't start the patient on TPA, because there is always a high you have to weigh the risk benefit ratio and the risk that would result from starting the patient on a TPA with these scenarios will be detrimental and result in a severe bleeding and other problems. So this is another surgical treatment, which is the surgical intervention for embolic stroke. It's called the Mercy Retriever, which is the mechanical embolus removal and cerebral ischemia. Mechanical embolus removal and cerebral ischemia, Mercy Retriever. Another invasive procedure to remove the embolus and increase the lumen of the blood vessel. Modalities to treat patients with aneurysms, because these aneurysms have a very thin wall that easily will rupture and result in hemorrhagic stroke. So they use something called coiling or clipping. And these are the metal clips they use to secure or to prevent the aneurysm from being ruptured, because the wall of the blood vessel of the aneurysm is very thin and fragile and easy ruptured. So that's one of the modalities called coiling. They do also the what is called clipping of the aneurysm, or coiling, coil or clip. Collaborative, again, it's the very comprehensive, covers all the all different types of deficits and dysfunctions, from sensory and motor, speech, swallowing, motor, movement, ambulation, sensory, sensations and feelings, and even emotional changes or alterations. All these aspects has to be addressed and to be treated. So again, we said the TPA, we use that thrombolytic therapy within 3 up to 4.5 hours. That's would result in the optimal result or outcome if you use it within that time frame. And the TPA is used to reestablish blood flow, because once this TPA, thrombolytic therapy or medication, is going to disintegrate and destroy that and break down the blood clot, then it will reestablish blood flow through the blocked artery to prevent cell death in patients with ischemic strokes, either thrombotic or embolic. Rehab, patient most likely going to be transferred to the rehab unit, and the collaborative care in the rehab care or rehab unit, it will be shifted from preserving life to decreasing disability. Like, we are going to try to eliminate the disability and attain optimal functioning. That's the highest level of the, I would say, like, the best objective, and the practical outcome from the rehabilitation care. So we are going to move from the acute to the rehab. So we are going to shift, our goal or our outcome from preserving the patient's life to lessening and diminishing and eliminating the disability, and to attain more of optimal functioning. So we have to maximize the patient optimal functioning and independent performance, like ADLs and other stuff. These slides provide some information or details about the role of RN and the assisted personnel, and taking care of, while taking care of the patient with stroke. We have to assess the under our role as an RN. We have to assess the respiratory status and initiate and to start and initiate needed actions like oxygen, for example, to maintain the airway, suctioning. Sometimes patients have a difficulty swallowing their own secretions, and we have to suction them. We have to assess the airway from being obstructed with these secretions. Positioning, head of bed elevated, that's going to aid or assist the patient in better swallowing, and also it will decrease the intraocular pressure. ICP will be decreased with the with the head of bed elevated. In addition to also, it will aid in the more respiratory capacity and functioning, and decrease the atelectasis or any associated lung problems with the immobility. So activity plus the head of bed elevated. So that's for the maintenance of airway, PNC of the airway, to decrease the ICP, the intracranial pressure, and to assist in the swallowing ability. So the upcoming slides continue to address the different deficits and like skin problems, GI, and the GI. We have to, so for the GI, first feeding should be approached carefully, so that we have to assess for the gag reflex before we attempt to to feed or either to allow the patient to eat. They will have also a problem with constipation. So and back to that, the dysphagia or difficult swallowing. If they have difficulty in swallowing, then and be assessed by or evaluated by the SLP, speech language pathologist. They do the swallow evaluations, and the swallow evaluations, they will provide us with details about the specific instructions, how this patient is going to be set up, how to even set up the tray and the food, and what type of consistency this patient should have, solid food, and the liquid also drinks, in terms of the drinks, the consistency of the fluid or liquid form. Is it going to be thin liquids? It's not thinned. If thickened, then we have to add the thickened at a certain consistency. It has to be also determined by the SLP. They will say this patient needs based on their evaluation, they need, patient needs honey thick liquids or nectar thick liquids. There is also a pudding thick liquids. So it goes from the lowest to the highest. From nectar thick, the higher is going to be the honey thick, and then pudding thickened. So that's from the lowest to the highest: nectar thick, honey thick, and pudding thickened. So the thickened liquids means that you have to make sure that patient liquid is being thickened, and even if they are independently going to feed themselves. So that's one of the risk for aspiration, and will result in choking and patient to aspirate. So the constipation is the most common bowel problem with patients with CVA. Constipation has to be addressed. Skin integumentary system, which is the skin, good skin hygiene, use of emollient stuff that to be applied to dry skin, making more more emollient, and less dry. Immobility, so we have early mobility attempts, positioning the patient on the weak or paralyzed side for only 30 minutes. Try to to limit the amount of, or the length of the time they will be on the affected side, not longer than 30 minutes. Then urinary system, Foley catheterization. Are we going to insert the Foley catheter for all patients with CVA?
No.
What else would, can be done or implemented so we will avoid, because we know that the Foley catheter is going to result in one of the risk factors or complications is the UTIs. So as much as we can, we try to avoid that. How? So effort should be made. There's a lot of discussion under under the this section or this system. The effort should be made to promote normal bladder function and to avoid the use of of the indwelling catheter. There's something called bowel and bladder training. Every 2 hours, you will offer the the patient go to go to the bathroom, or if you're not able to to use the commode, or it depends on the severity of the case, or use the bedpan or urinal. So we have to every 2 hours you have to offer them that. If they have that, you still have that sensation, they're able to to perform it. So there is certain things they can do with them. Fluid intake, there are some medications to be given. So we have it's called program. That's why it's comprehensive. So it includes a lot of elements and interventions. So it's a bladder and bowel program is very important topic to review from the textbook. I would say extremely important because patients with CVA, they need, we have to understand how to implement these type of programs, bowel and bladder program. So training, sorry, bowel and bladder training program. The last thing that just finish with this, and then the result. I mean, the rest of the slides will be questions. The last thing is that it's called the homonymous hemianopsia. You can just call it hemianopsia, and it is the blindness in one half, just one half or half, which is half of the each visual field. It could affect both at the same side, or contralateral, which is other sides, or just one eye. It depends on the scenario, which means it depends on the insult of the brain insult due to that stroke, hemorrhagic or thrombotic. Sorry, hemorrhagic or thrombotic or embolic, like ischemic versus hemorrhagic. So there are different scenarios here. See how you have like the left side completely, patient is blind, is just with the left side. Then the stroke did not affect didn't affect the right side. Then we have another scenario. So each scenario is would correlate with the location or the site of the brain insult due to that stroke. So number 2, for example, if that's blood clot or hemorrhage or insult, will be like on the optic chiasm, then this is what the patient would have a loss of the hemianopsia in both eyes on the external hemispheres or the external side, halves. So I'm not, asking you to know, the specifics about the each type or which, site will result and, what correlates with resultant, deficit. But at least just to know the concept of hemianopsia is that the patient would have the most common form would be of the one side, or one half of the same side. Like for example, the left half of both eyes, something like this. So patient, let's say that this patient had a right stroke. Stroke affected the right hemisphere, right hemisphere CVA, which resulted in a left hemianopsia, homonymous hemianopsia. You can just call it hemianopsia. So the patient is unable to see anything on the left side. So this requires that as we approach the patient, we have to make sure, because the patient has something called, they use something called scanning in order to see or trying to, to visualize or, see anything, you kind of, come into the room with the food, with the meal, with the tray, with food or whatever, with anything is trying to, to see that person coming into the room. They will scan the room starting from the left and then going to the right side. So it's better that we approach them always from the side that they can see us. So there's a lot of nursing implications when it comes to the human nausea. So I would encourage that you refer to the book. And the last thing is the assistive devices that we can, this is part of the OT and PT, like physical therapy and occupational therapy. They have, that's their specialty to identify the need or the specific tools that needed or required for patients with certain or specific type of deficits. And there's a lot of things out there, on the OT and PT, they can consider and use and prescribe for those patients with CVA with certain motor deficits, so they can be more independent, and they can, especially when it comes to feeding themselves, and they can eat more independently, not being relying on others to feed them. In addition to also other things, they can help. They can dress, to dress up, put their shirt on, button their shirt, or there's a lot of devices that can be used and assistive tools to assist them doing all of these ADLs and other functions. So again, the rest of the question, the slides, scenarios or case studies and questions, and I will definitely put the answers in the Blackboard because we don't have time for that. All right, so running out of time. Let me stop recording.